Brijesh, who is answering today? Hello, who is answering today? Swastik?
Hello, sir. Good evening,
Who
sir.
is answering?
I'm
Sachin.
Dr. Yes, sir.
Okay, Sachin is answering. Who else?
Me, sir. Hussein.
Hussein.
Yes, sir.
Okay, and who else? Anyone else? Okay, fine. Okay. Good evening, Pankaj Bhai and Gite.
Good evening, sir.
Just waiting for Ganesh Bakshi. Once he joins, we start.
Sir, good evening, sir.
Good evening.
Oh, Ganesh Bakshi. Yeah, good. Ganesh Bakshi. Nice to hear from you.
सर वो लास्ट वीक थोड़ा प्रॉब्लम था
सर मुझे लगता है कि माहेश्वरी सर ने जो व्हाट्सएप पे लिखा है वो अपने चैट बॉक्स में, तो नंबर ऑफ स्टूडेंट्स आर नॉट सो गुड सिंस लास्ट 3 to 4 क्लासेस.
ओके.
तो उसमें कुछ इम्प्रोवाइज करने के लिए, क्योंकि आज एक मेरे ख्याल से वेस्ट जोन या नेशनल का जियो टीवी का भी क्लास है.
डॉक्टर गीते वो कल हो गया है.
हाँ, लेकिन ओवरऑल सर अटेंडेंस not happy. I am agreeing with your statement what is placed in chat box.
Actually, that chat I had written specifically to you only.
No, last time I think almost 48 students had attended. Before that there were little less.
तो सर अगर मुझे टारगेट करके लिखा है तो मैं एश्योर करूंगा कि मैं अगले बार से रहूंगा वहां पे.
No. So, no, the idea is that the one thing is that the message should go to each and every student. That is the most important thing. Or see, that is why we have given the full list well in advance. That in which class what we are going to discuss. So they know well in advance. Number one. Number two, in our the teachers group, you can give the suggestion how to go about, how to it should be more helpful to the students so that more students can attend.
नहीं, दूसरा ये बात है सर कि बहुत सारे लोगों ने टेलीफोनिकली भी कांटेक्ट किया था कि ये जो अपन ऑलरेडी पहले ही उसका टॉपिक बता देते हैं.
हाँ.
तो बहुत सारे लोगों को ये रिक्वेस्ट था कि एटलीस्ट एग्जाम के पहले कुछ महीने कम से कम विदाउट गिविंग द टॉपिक वो अपन क्लास लेना चाहिए, सो दैट कि दे शुड बी थिंक इन ब्रॉड वेज एंड दे शुड बी रेडी टू गिव द एग्जाम इन जैसे नेशनल लेवल का जो एग्जाम रहता है वो फेस करने के लिए दे शुड बी रेडी. ऐसा.
Yeah, so that also we will do, but at the same time I told you, this time we are going to have, I already discussed with our Saifi hospital and some pharma companies also. We are going to have a proper mock exam. Like, we will have multiple tables. Every student will be giving 2 or 3 tables. They will go one instrument and one short case or something like that. And we will have a proper mock exam this time as soon as DNB theory exam is over.
Agreed.
So that way here if we only 2 or 3 students are answering, but in that whichever whoever comes there, he will be evaluated or he will appear in 2 or 3 items.
Only issue is that कि अगर पहले ही हमने अगर उसको टॉपिक बता दिया है तो that particular person will come with that particular topic only, and वो broad way से thinking नहीं करेगा, ऐसा एक सब बहुत लोगों का कहना था. तो अगर चेंज कर सकते हैं, टॉपिक नहीं
Whatever
बता
you
के
say, but
immediately.
we'll take the, because till last time na, the students were saying that if we are not given the topic, we don't know what to read, and then we are afraid to answer because then many
सिस्टम
questions we are not
सर
able to
अपन
answer.
एक काम कर सकते हैं कि सिस्टम बता सकते हैं. जैसा फॉर
Okay,
एग्जांपल अगर लोअर ट्रैक है तो लोअर ट्रैक, या फिर प्रोस्टेट है तो प्रोस्टेट, लेकिन उसमें
okay,
फिर सीए प्रोस्टेट है कि बीईपी है ये नहीं बताना. ऐसा और
okay,
थोड़ा तो भी उनको थिंक करने के लिए स्पेस देना चाहिए, ऐसा मेरा भी पर्सनल ओपिनियन है.
okay. Fine, we can go ahead. We can do like that.
यस सर, यस सर, यस.
Definitely.
थैंक यू सर, थैंक यू.
Yes, yes, sir.
सर दूसरा क्या चीज़ हो रहा है ना कि many of the people if they are slightly worked up and tired, this is what I
Yeah,
have seen at 2-3 colleges कि they say कि okay recorded copy तो मिल ही जाएगा.
yeah. That is another
That
thing.
is a very strong factor which I see. मतलब I'm much junior to you. मतलब this is a very common factor when I talk to students कि ठीक है
Correct.
सर recording तो मिल ही जाएगा. So they don't
Yeah,
understand
that's
the
true.
importance of the live thing where the questions are asked and how much problem is there in answering them at that moment. So
Fine. Yeah, I agree.
nobody wants to do uh, or see the practice of that.
Yes, yes, yes.
मुझे लगता है ये सबसे strong point है.
Yeah. So how to?
इम्प्रोवाइजेशन का क्या है सर कि इधर उधर यूएसआई वगैरह वगैरह सब में जाके थोड़ा थोड़ा वेरिएशन होता ही है.
Hmm.
अभी सम 4 days बैक मंडे को सबनी सर मैं एंड वन मेडिकल ऑन्कोलॉजिस्ट वी हैड डिस्कशन ऑन locally advanced and metastatic RCC. So that
Okay.
was from NB DNB का thing. So
Oh,
उसमें भी whatever people were there, we don't know. It is compulsory from the DNB, compulsory to attend this. So most of the people I asked at Hinduja Urology, they said कि हम लोग लॉग इन करके कुछ नहीं देखते, ऐसा छोड़ देते हैं.
hmm.
All told me the same thing. लॉग इन करके हम लोग छोड़ देते हैं. And then at the end, Sabnis sir also said that this will be available as a video on the NB platform. Finished.
That's true. So let us in our group now. Let us find out some good alternative.
नहीं सर, वीडियो अवेलेबल करके देना कोई गलत बात नहीं है,
नहीं
क्योंकि एग्जाम के पहले उनको बेनिफिट हो जाता है, लेकिन वो दैट कैन नॉट बी अल्टरनेटिव टू द अटेंडेंस ऑफ द लाइव सेशन है सर.
Yeah, so I feel that we request, we know again and again to all the students that please listen to us or answer in a live Zoom meeting, and then later on you can hear it again so that your basis and everything will become very clear. So that is what we will request. So now routinely we'll put it on the our group and we'll request them so that more and more students can appear. So let us do that way.
If they are coming live, good for them only, no, sir.
It is very good. So
Yeah, because this is a platform where they are getting to practice, sir, rather than just listening to the video.
yes.
And at every step, we are correcting them, we are giving inputs, we are putting in effort. So if they put in the effort, it's good for them only.
Yeah. So now,
And we are discussing so much.
yeah. So we request all the students who are attending now to tell your colleagues, your friends that when they attend the live discussion, it is much more helpful. So you tell them that please finish your work as soon as possible and join. That is the best way. And then again, you can, when you listen to the same talk again, you will understand many more things and you will remember many things. Fine then. Okay. So let's start then.
I have another request. Those who are
Bol Ganesh.
instead of putting your phone numbers like Samsung 22, iPhone 16, please put your names.
Yes. Correct. This is a request from all of us so that we know who are the students regularly attending, and and then I can also request you people to answer. Come forward and answer. That is the best way. Fine then. Okay. Let us start then. Okay, so Sachin and Hussein, two of you are answering, correct?
Yes, sir.
Yes.
Okay.
Fine. So one of you read it. Yes, Sachin. Brijesh, read it and just tell them.
Yes, sir. Good evening, teachers. So a 68-year-old male came with a complaint of difficulty in passing urine, poor flow, and increased frequency all since 4 months.
Yes, Sachin, this is a history. What are the questions you want to ask?
Sir, I would like to ask other urinary symptoms like poor flow, already given frequency, then nocturia or straining is there or no? Yeah, associated with dysuria or any hematuria history. And history of any fever in the past. And I would like to ask any history of any medication, using any alpha blocker or any medications regarding as per concern about the age, and any history of any instrumentation or catheterization.
Hussein, you want to add anything?
In spite of asking a history haphazardly, whenever you listen the chip complaint, you should have at least 3 to 4 diagnoses in your mind, probably.
Yes.
And you should ask the history as per that diagnosis to rule out that diagnosis and confirm that diagnosis. Otherwise, asking one history of this diagnosis, one history of that diagnosis, it will haphazard way, and it will be a poor presentation. अगर 68-year-old मेल है और उसको अगर LUTS का हिस्ट्री है, तो यू शुड हैव टू बी डिसाइड फर्स्ट कि इट इज स्टोरेज है या वाइडिंग है. फिर स्टोरेज है, मोर प्रोमिनेंट स्टोरेज है कि वाइडिंग है, उसके हिसाब से क्या क्या डायग्नोसिस बन सकता है. फिर वो डायग्नोसिस के हिसाब से निगेटिव हिस्ट्री एक एक पूछ लिया, तो एग्जामिनर विल बी मोर हैप्पी कि भाई यू आर वेरी प्लान्ड and you have some diagnosis in your mind. Otherwise क्या है कि haphazardly history of instrumentation, some another times you will tell history of instrumentation, then history of lithoria. ये सब चीजें कहीं किसी के साथ मैच होती नहीं है. तो ये ऐसा haphazard वे से प्रेजेंटेशन करना छोड़ दो, और जहाँ जरूरी है वहाँ पे लिख लो पहले कि भाई ये नेगेटिव हिस्ट्री, इसका मैं ये 4 पॉइंट पूछने वाला हूँ, ये दूसरे डायग्नोसिस का ये 4 पॉइंट पूछने वाला हूँ. तो एग्जामिनर को इम्प्रेस करना है, तो ये बहुत जरूरी है.
Yes, sir.
Like you can see that all our presentation, you will see that there is a format. So you also in your mind, you must have a format for the lower tract symptoms, or for the kidneys, or for the stone, or whatever it is. And once you think that this is one of the diagnoses, accordingly you ask the question. Fine?
Yes.
Yeah. Brijesh, Hussein, you want to add anything?
Yes, sir.
Sir, Hussein, like, sorry to interrupt. Like Gite sir said, if that is there in your mind, when examiner asks, why did you ask this, then you can defend it. Otherwise, you cannot defend it. Sorry, go ahead.
Exactly.
So apart from Sachin's history, sir, I would like to ask about this medical history, whether he is taking any medications for the same, or whether any medicine which is responsible for the symptoms in form of antihistaminic, antidepressant, or any other medicines. I would like to also rule out there is a history of jaundice or back pain is there or not. And apart from that, any patient is sexually active or not, sir. I would like to add.
So, Hussein, this patient has a history of 4 months. Do you think 4-month history will be there in a patient who has medications as a cause of LUTS?
So, sir, I would like to elaborate the history first, starting from the 4 months, whether it is a sudden in onset or gradual in onset, whether patient was relatively asymptomatic before 4 months or the symptoms was there and the suddenly was over the 4 months, sir.
Sir's
So,
question was that will the medicines cause that in 4 months? Then why you are
most
going on
likely, sir.
elaborating the history? Be specific, Hussain.
Least likely, sir.
When examiner says that, you should say yes, sir, and take a one step back and say okay, sir, and go ahead. When you keep talking, then you land up in a trap. Chal.
Brijesh, go ahead.
So I would just make one small suggestion. One better way of answering here would be that go back to the last slide, Brijesh. This is a 68-year-old man who is presented with voiding symptoms. I would want to elaborate the history more to calculate the IPSS score and assess how much bother the patient has. इतना बोल के रुक जाइए. ठीक है. Dr. Gite, how does this sound?
आई एम एब्सोल्युटली एग्रीइंग विद यू सर, क्योंकि क्या है कि यू शुड गाइड द एग्जामिनर, क्योंकि एग्जामिनर तो ऑलवेज बैठा रहता है कि आपको कंफ्यूज करने के लिए.
So instead of saying कि मैं frequency, urgency, nocturia, X, Y, Z, just हमारा aim क्या है history लेन? We want to calculate the IPSS score and get the bother so that we can move ahead with the further treatment decisions.
एग्जैक्टली सर, क्योंकि आप अगर उसको स्कोप दे रहे हो, नेक्स्ट क्वेश्चन क्या पूछने का है आप खुद डिसाइड कर रहे हो.
Okay, sir.
Sterling, please go ahead.
Apparently asymptomatic before 4 months, started developing the following symptoms. He had poor flow, increased frequency, sense of incomplete voiding. All the symptoms were gradually progressing with no specific aggravating relief factors. IPSS score is mentioned. He is not sexually active. Symptoms were bothersome and had a significant negative impact on daily life activity.
So how do you analyze the situation now, Hussain?
Sir, it would be a 68-year-old age patient with associated storage and voiding symptoms. So I would like to put a differential here, whether the patient having the bladder outlet obstruction due to this benign or malignant cause, it would be associated with bladder stone.
You see, again, you have put yourself in difficulty. Why did you say bladder stone?
So this, sir, 4 month onset is there. So, and even the storage symptoms.
What in this history suggests towards bladder stone?
More storage symptoms, sir.
So just say that based on this history, patient appears to have a moderate intensity lower urinary tract symptoms, moderate intensity bothersome lower urinary tract symptoms, suggestive of bladder outlet obstruction due to prostate, could be benign or malignant. I would want to proceed further
Further
history. ठीक है, ऐसी कोई भी चीज ना बोलो जिसको आप एक्सप्लेन ना कर सको. ब्लैडर स्टोन इसमें कैसे एक्सप्लेन करोगे? हेमेचुरिया नहीं है, इंटरमिटेंट ऑब्स्ट्रक्शन नहीं है, पेनफुल वॉइड नहीं है. These are the common ways of bladder stone presents. So what further do you want to ask?
Sir, I would like to rule out any previous history of any acute urinary retention, previous history of catheterization or instrumentation is there or not.
बताइए, आगे बताइए.
Brijesh, complete the history.
So he didn't have any history of retention or incontinence. No any burning micturition previously. No hematuria, lithuria, dysuria. No any instrumentation. no abdominal pain, fever, no puffiness, breathlessness, or any limb edema, no backache, bony pain, or weight loss.
Fine. Sachin, now what you want to do?
I would like to examine the patient, sir.
अरे
Very good.
सचिन थोड़ा कोमॉर्बिडिटीज वगैरह पूछ लो.
Yeah.
Yes.
पूछना है
Any
नहीं पूछना है?
So what is important family history in this case?
What is the significance of family history here, Sachin?
sir, some
Casually speaking, these symptoms are there to 75% of the males at that age.
suppose if you are considering CA prostate, sir, if first degree relatives are affected, there are more chances that patient will be having the malignancy, sir.
Sure. And do you think
Any
benign
mutation, sir?
prostatic hyperplasia is familial?
Sir is asking, is BPH familial?
No, sir.
Are you sure?
Not sure, sir.
Then ask your colleague.
Yes.
Simple. Google में डाल के देखो. Is benign prostatic hyperplasia familial? You will get a very nice answer. I think you should, in a BPH class, or rather than that, we can discuss it here. It can be familial. I can't tell you exact percentage, but it can be. It's about 35+% familial. And there are genetic predisposition factors for that, but whatever, I mean, the intensity of presentation can be different, but it is familial. Anyway, let's proceed. So this is supposed to be a CA prostate class. Family history yaad rakho, but it's about cancer and benign both. So history, I think, is pretty simple in this patient.
Yes.
Sir, if we are considering a malignancy as a one
Right.
cause, sir. Sorry, sir.
Yeah,
So
go on.
can we ask about this other malignancy associated with the BRCA, sir? So can we ask about this history of
वो
colonic
family history में
pancreas?
पूछ सकते हैं ना, other when they any family history of somebody like you know, aunt or somebody mother having breast cancer, ovarian cancer, somebody in the family having prostate, pancreas. These are the BRCA ones.
Right, sir.
So
But,
rather when Dr.
but
Bakshi
that will
asked
be
you,
still, instead of wasting your time on history, I would still suggest the same sentence. Family history is not contributory, provided the examiner asks a question, you need to know all these things.
so if you are asked what family history, then you say that I would want to know family history of cancer prostate in first degree relatives and history of 1, 2, 3, 4 in other relatives.
Yes, absolutely. So maybe the message which somebody has put, family history of advanced, I mean, sorry, not family history of advanced prostate cancer. History regarding symptoms of advanced prostate cancer. Generally, they are all same, weight loss, loss of appetite, back pain, bone pains, bony pains, jaundice. That's it.
So again, as I say in every class, try to spend as less time in history as possible. Okay. So speak less and keep on pushing the examiner for the next step.
Sir, if someone is suspecting a malignancy, then he should be very much clear in his mind that the history should be confined to the organ, history should be confined to the local advancement, and history should be confined to the metastasis. ये इतना क्लियर कट रहना चाहिए कि दो पॉइंट अगर हर चीज में पूछ लिया है तो वो क्लियर कट हो जाता है.
So you see, based on the history up till now, there is no hint of it being malignancy. So we are just talking of a patient with bladder outlet obstruction. So next you say, okay, the comorbidities are not there. He's a non-smoker. Family history is not contributory. I want to examine the patient.
Yes.
बताइए एग्जामिनेशन फाइंडिंग्स, या आप लोग क्या कुछ स्पेसिफिक कुछ पूछना चाहते हैं?
General followed by systemic examinations.
So general examination normal.
Normal, sir.
I would want to do a systemic local examination.
Local examination is normal, sir. For rectal examination, had grade 2 enlargement of the prostate. Prostate was hard. Medial surface was palpable. Rectal mucosa was mobile. Rectum was empty and there was no any blood.
Okay, so Sachin, what is your clinical impression at this time?
Sir, as the prostate is hard in consistency, but there is no such firm palpable nodule, sir. One of the differential diagnosis will be CA prostate, sir, and benign enlargement of prostate still. I would like to confirm with the further investigations.
Okay. I mean, you can say that my likely diagnosis is CA prostate because the prostate is hard in consistency. If
Yes.
examiner pulls you too much, then say that it still can be, you know, a focus of chronic prostatitis, which can be hard with benign prostate. I think we can go ahead.
Yes. So what investigations?
So I would like to. So I would like to do, sir, complete blood count, renal function test, urine routine, ultrasonography, kidney ureter bladder, along with full bladder PVR and uroflowmetry, and along with that PSA, sir.
Okay, so PSA has come 13.3, creatinine is normal, rest everything is good. Where is creatinine? Yeah, it is normal.
So what will you do next? You have a hard, whatever, nodule palpable on in the prostate.
So Sachin, based on this, are you happy with this, or you want to repeat a PSA after some time, or you want to give some antibiotics and recheck PSA?
Sir, but in this patient, sir, I would not like to repeat, sir, because prostate is hard, sir. So we are suspecting malignancy already. So there is
Perfect.
no advantage of
So it is
repeating.
only in the screening scenario, if the PSA comes elevated or borderline elevated with DRE benign, that time you should say that I would repeat a PSA after 1 month. Unless
Yes.
patient is running fever, don't talk of antibiotics and repeat a PSA. That is a concept which is given up. So what next now, Sachin?
So I would like to do, sir, MP MRI of prostate, sir, for local staging. After ultrasonography, I have not.
Why do you say local staging? We
Exactly.
still have not
We have not
diagnosed
diagnosed
prostate
yet.
cancer.
We want
You
we
should
want
really choose
to.
your words carefully. Like, see, there are studies which say do MRI before biopsy, but there are reasons mentioned in the discussion of those studies, you know. So staging is like, I know that say kidney has a cancer, then I'll do staging. I'll do a local staging investigation. I might do some investigations for knowing the distant staging, the nodal and the distant.
I want to know the pyrites grade, sir, first in the MP MRI.
How is it going to change your further plan?
If pyrites 4 or 3,
So let
4
me
or
ask you reverse question before you answer sir's question. This is PSA 13.32, 868, I think. Okay, you do an MP-MRI, it says left transitional zone mid gland, pyrites 3 lesion, 1.1 by 1.5 centimeter. Now what you will do?
So I can target the lesion, sir. That is the advantage of MP MRI, sir.
Pyrites 3 lesion is a in-between lesion. You may biopsy, you may not biopsy. Why are you biopsying?
But we have the
If I am the
clinical
patient, I will ask you
clinic.
many questions on that. Biopsy may be painful, biopsy may be trouble, biopsy may cause infection, PSA
But
13 million.
PSA is in high, sir, and clinically also we are suspecting the malignancy. So I want to confirm the diagnosis.
Okay.
Yes.
And suppose we didn't have we had a normal DRE in this patient, then with PSA
Still,
13.32 with Pirates 3, how will you decide?
then it still we have to proceed for MP-MRI, sir.
No,
We are
no,
not.
sir has said that the DRE is
Yeah, I have
benign.
already said. MP-MRI Pirates 3
MRI shows
lesion.
Pirates 3. So
There
then
was no DRE. DRE was
DRE
not.
benign.
PSA was 13.32. Then how do you proceed?
So basically, sir is asking, how will you justify whatever you have asked for?
If you are saying biopsy at Pirates 3 now, how will you justify? The earlier scenario
Sachin,
was easier to answer. There was a DRE related finding which
Sachin,
supports your biopsy.
you
I
may be
understand.
right. Just justify yourself, right?
Yes, sir.
Just make it clear to sir why you want an MPMRI.
Sir,
You
still
may
still
say
PSA
that PSA is
sir,
elevated, DRE is normal, but
is
yet
elevated
PSA
and
is
there is no
elevated.
UTI also. Yes,
You may want to differentiate between prostatitis and malignancy, morphological staging. Later on, if you want MPMRI,
No,
you may not be able to do.
Hiren,
Yes.
Dr. Ganesh has already given the MP-MRI findings.
Yes, sir.
Yes.
But I'm just telling him
Yes,
that
yes.
now that you have the findings and sir is asking why you wanted MRI before that, you can justify it. Now, when he has said MRI, he can
No,
justify
the
it, sir.
question was not that. The question was that now that MP-MRI shows Pirates 3, how and why he should do a biopsy.
On what basis you will decide
On
that
what
you want a
basis
Pirates
how do
3
you
in a
decide
biopsy?
whether you should do a biopsy or not? In a
I can say
patient with-
other way around also. Pirates 3, why should I do biopsy?
Hussein, you want to try?
We can do, sir, PSA density. And if the PSA density would be less than 0.15, then we can go ahead with a biopsy, sir.
Not less than, more than.
Sorry, more than
More
0.15.
So
Sorry.
European guidelines do say 0.18, so that you can remember. PSA density, that's a good thing to as a guide. That is what we decide with Pirates 3. So let's come back to the case quickly. So here you are doing an MRI, MP-MRI, for which reasons? One is he said already, Sachin, I think, as a guide to the site, right, Sachin?
Yes, sir. To target the lesions.
Right.
Apart from that, sir, if the Pirates 1 or 2, we can avoid the biopsy also, sir.
Yeah, that is true.
But
I
well, in this
fully agree.
patient with a
But
clinically
palpable, yes,
No
sir,
difference.
agree. Not indicated, but if it is not
Yes.
palpable, then one indication.
So in a patient with palpable disease, the role of MRI would be, one, you know where to do the targeted biopsy. And it also helps you in local staging once the disease comes positive, because post biopsy, you will not be able to do MRI for at least 4 to 6 weeks.
Absolutely.
Anything else you would want to add, Ganesh here?
Okay.
Sure.
I think beyond MRI, we don't do anything much.
No. So reasons for MRI here?
No, I think there is no grossly for exam. I think these are the two reasons. Theoretically, so they say whatever. Matlab,
Right.
you don't need extra biopsies. You will detect only clinically significant cancers. But then, particularly here, we are having a palpable nodule, so no.
So do you have the MRI images?
So Ganesh,
Yes, sir.
in this, even if it is a palpable nodule, hard palpable nodule, ultrasonography will be definitely have a role, correct? Ultrasonography.
Technically, we do ultrasound guided biopsies, but only ultrasound, matlab, we'll still settle with MP MRI only before the biopsy.
No. I'm saying in the exam, they must talk about this sonography also.
Yes, sir. Guided biopsy.
No, that is later. But before that, ultrasonography, abdomen and pelvis or cube, that too they have to say, na, because they have to see the upper tract and other things.
We should ideally, sir.
Correct. So that
True.
is one thing.
I
And
think
what
we
is the role?
should.
And what is the role of uroflowmetry? I feel that even the uroflowmetry, because most of the time these people are not saying uroflowmetry is also very important,
Okay. Sir,
because I'll tell you why. Suppose this comes negative, biopsy comes negative, and patient already have obstructed flow,
right, sir.
then your management will differ.
No, sir, agreed. I was just going to say that. So what means in my practice, what I do is I go this way only, MP-MRI biopsy, and then somewhere in between, I would do a uroflowmetry if needed, if the obstructive symptoms are quite high.
Ah,
Because if I'm anyways going to do a radical prostate, it is fine only. But in case the patient does not choose surgery and goes for radiation, then with the help of uroflowmetry, we can actually see, have a baseline study and actually see if he's grossly obstructed or it's okay. Like, because radiation, when given, it enhances the obstruction as an acute side effect when the patient is taking radiation.
fine. So I think they should say that in lower tract, lower in the urinary tract symptoms, one of the reason to do is uroflowmetry is that if there is no malignancy, then we can decide whether he needs a TURP or medical management. One thing. And two, as you are saying very rightly, even if it comes out to be malignancy and you want to give radiation, that time also this flow will help us to decide whether we want to do first TURP and then go for radiation or only radiation if the flow is very good.
Hmm.
Correct? So that is a way they can defend themselves.
So a better way will be when you ask for the initial investigations like CBC, urine routine, creatinine. That time itself mention
Uroflowmetry.
USG-KV and uroflowmetry.
Agreed, sir. I was just going to ask that question to you all. Like, is it okay if they add it to the basic list? Because this patient had a very specific history.
Exactly. So because I was saying that most of the time na, the students are never asking about uroflowmetry. So
Agreed.
anyway, Brijesh, before going for now, just show them uroflowmetry and ultrasonography, whether there is anything there.
So average flow is 6.1 ml per second.
Yeah. So it is suboptimal, it is borderline, or
Borderline
maybe,
obstructed.
yeah,
As the median lobe also.
yeah. And the post void, and the bladder scan, the post void residual is 240 cc. Okay.
10
That is
ml.
one thing.
10 ml.
Yeah. 10 ml. Sorry.
First one is 10 ml.
10 ml. At the voided volume 240. Fine. And sonography, just comment. Anything is there?
Yes, so the
No,
prostate.
no, show the images, please.
Yeah.
Sorry, it is a ultrasonography of abdomen plus pelvis. Showing this liver echo texture looks normal. I'm not able to identify which one is right and left kidney, sir. But if on the second panel right side, if the bilateral kidney has been shown, then both kidney parenchyma looks okay, no HNHU, sir. On this third panel, the first image bladder is not well filled. On the second row, third panel, prostate looks enlarged, but still it is the with the empty bladder, sir. So I'm not clearly able to define this whether it is clearly enlarged or not.
So I think it's a very good point you have made that let's not comment on bladder wall thickness in a partially full bladder or nearly empty bladder. So I would say that kidneys look normal, bladder, though suboptimally filled, the wall looks thickened and prostate looks enlarged. And just move forward. Okay, so we have done all this. Now
The prostate is enlarged, appears irregular, measures about 5.9 cross 4.7 cross 4.1. Weight is approximately 61 grams. Parenchyma appears heterogeneous. Fat planes between left anterolateral aspect of the rectum and the prostate is not appreciated. In right SV appears to be bulky and heterogeneous.
चलिए, so we have this, we have the MRI report. Now what next? We haven't discussed the MRI. Yeah.
Next.
So on MRI, prostate is approximately 60 cc. Peripheral zone, there is an evidence of ill-defined moderate hypointensity in T2 weighted images on peripheral zone bilaterally at the apex, mid-gland level and the base, involving posterior lateral and posterior medial sectors. The lesion is in the right posterior medial and posterior lateral sectors showing moderate restricted diffusion on DW weighted images at higher B values. There is loss of normal TW weighted hyperintensity signals in bilateral seminal vesicles, which shows mildly restricted diffusion with hypointensity on ADC maps. So overall, it is moderate prostatomegaly with the hypertrophy of median lobes, few heterogeneous intensity nodules within transition zone at the base and the midgland, with few of these showing indistinct hypointensities on ADC maps. And ill-defined moderate hypointensity T2 weighted images in peripheral zone, bilateral apex, midgland, and the base, involving posterolateral and medial sectors of right side with restricted diffusion on DW weighted images with higher B values. And there is loss of hyperintense signals in bilateral seminal vesicles. There is suggestive of malignancy involving seminal vesicles also.
So Sachin, what is your impression?
फाइनल इंप्रेशन दिखा दो ना, कुछ नोट भी पॉजिटिव था ना.
This is a right external iliac lymph.
Yeah, 13 by 11 millimeter. Okay. So where do we reach?
So it would be sir T3B and one M0 disease, sir. We have to now look for this score and grade group, sir.
Correct.
So I would like to do this systematic 12 core biopsy, and if it is suffice, then we can do along with targeted biopsy also.
Okay.
Sir, in this report, they mentioned loss of
Hello.
signal between seminal vesicles. So,
Perineal transrectal.
Ganesh, you were not audible. What did you say?
sir, they mentioned there is loss of a normal T2 weighted hyperintense signal between the bilateral seminal vesicles, which showed mildly restricted diffusion. So, seminal vesicles also we should consider it is involved or sir.
Yes, we should say that there is a suspicion of SV involvement.
Looks like involved na, by the MRI.
Yes, yes. So Ganesh, you could discuss about the various modes of biopsy.
That question I was asking, what type of biopsy? But if we see this whole report, This looks pretty. So what they have said is hypointensities which are suggestive of cancer in the PZ bilaterally at apex, midgland, and base. So almost the whole gland is involved,
Yes,
probably.
yes,
Something like that is mentioned in this report at least.
yes.
With lesion in the right posterior medial, right posterior lateral sector, and then the T2W weighted hyperintense signal in bilateral seminal vesicles
Hmm.
with restricted diffusion, which also suggests malignancy of the seminal vesicles. So we go ahead. The question was whether we should do transperineal or transrectal biopsy.
Transrectal biopsy will be more feasible, sir, in this case.
Okay. I don't think feasibility is a problem. Transperineal can be easily done, but with current meta-analysis which came out, I think it's okay. You don't have to vouch always for a transperineal biopsy. So
So again, Sachin, the
transrectal.
better way to answer here would be that although the risk of infectious complications will be marginally low in transperineal, in our center we have always done transrectal, so I would advise a transrectal trust-guided biopsy. And as Hussain said, it would be a systematic with targeted biopsy.
That is nice. So what is the biopsy done here?
Biopsy report बताइए ब्रिजेश.
So as per MRI, all cores positive, or this is the only page? Left apex 4+5 9, left mid 4+5 9, left base 4+5 9. So almost the full gland is having cancer, as we saw.
Yes,
in the
all
MRI.
cores positive.
Yeah.
Hmm.
So base report comes here is 4+5 9, grade group 5. So Sachin, what is the small meaning of ISUP prognostic grade group?
Sir, it is very poor prognostic, sir, very high grade.
No, but why, what is the overall meaning of ISUP grade? Suppose if this comes ISUP prognostic grade group 1 and grade group 5. So what do you think about the prognosis?
So
You
what
just
is the
mentioned one
clinical
word.
significance of grade groups?
You said
This is
highly progressive. That is what one word you use. But does that mean death for the patient?
This is aggressive
No.
tumor, sir. This will be the grading will show the aggressiveness, sir, of progression of the disease and chance of early systemic metastasis.
Okay. So grade group can suggest that the disease is aggressive with a higher incidence of having systemic disease, more aggressive disease. This disease may also not respond very well to therapy. It may turn castration insensitive in a faster way. All these things join up for grade group 5. Okay, let's go ahead. So that is the biopsy. So now what will we do?
Sir, regarding biopsy, I had one doubt, sir.
Yes,
Suppose some
please.
patients more than hundreds of PSA and very hard means mostly malignant nodule. Some people will say you can do just finger guided biopsy. That scenario also we can give option of the transperineal or there is no option, sir.
नहीं, biopsy तो कुछ भी कर सकते हो
Okay, sir.
transperineal या transrectal but basically as Pankaj sir answered, you will have to keep one point at least. Transperineal has a slightly low incidence of infection.
Yes.
And such a transperineal will never be finger guided.
No, sir. I was asking about transrectal, sir.
Yes.
Transrectal, okay, but usually we still say trust guided only. I think that finger guided never comes in the Western literature. We do it in India because earlier many times we wanted to save money. We would take the patient in a minor OT or baju mein aise and just check the coag profile and do a finger guided biopsy.
Okay.
See,
So Ganesh,
I
Ganesh,
do
what?
nowadays. See, earlier we used to do both perineal as well as transrectal when the ultrasonography guided, like, trust was not available. Now I will do it only if it is, I know it is a metastatic disease. When I do PR, it's a very hard prostate. The mucosa is involved. PSA is more than 100. And I know that I'm not going to do like, radical prostatectomy. I just want a biopsy.
Yes, sir.
So I will put a finger and just take a biopsy because I'm sure wherever I'll put my needle, I'm going to get the result.
Okay.
So that is the only place where you can do it. Understood?
If this is acceptable in exam, theek hai, but in all those other forums, scientific
Yeah,
forums.
yeah. Again, this is not to be said in exam. This is what I'm saying practical. In
Yes, sir.
case if you want to save the patient's money and if you know it, then only then. In exam, just follow the protocol. You will say, I will do the transrectal ultrasonography guided biopsy.
So Sachin and Hussain, let me simplify this. So as a standard answer will be, I will do a trust guided systematic and targeted biopsy. But in case if the examiner asks you, can you do finger guided, in which situation, only then say this, that if it is a severely means clinically advanced malignancy which is felt hard nodular fixed mass on the digital rectal examination, it can be done. And again, take benefit of your institute. End up by saying, in our institute we do only trust guided.
That is easy for you in the exam.
ठीक है?
Yes.
एग्जाम में एक अच्छा तरीका है किसी भी डिफिकल्ट सिचुएशन से आने का बाहर कि हमारे इंस्टीट्यूट का प्रोटोकॉल ये है, and agree with the examiner and immediately come out saying कि in our institute we do trust guided.
I will suggest all of you that whatever Dr. Pankaj Maheshwari has given you answers in all these lectures, I advise you to write it down like a quote and remember it. I'm not joking. I'm telling you frankly. If I am
Yes,
an
sir.
examiner and my student will answer like this, I will be very, very impressed and I will be very happy. Because it shows that how clear thoughts you are having in your mind and you have understood the subject well. That is the most important thing. Okay, fine. Go ahead. So, Hussein, now what you want to do?
So, sir, till now the patient having, as per NCC and EU guideline, very high risk, locally advanced CA prostate. So, sir, I would like to do the metastatic workup in terms of by doing a PSMA PET scan, sir.
Okay.
Okay. So क्या है PSA में PET scan? Okay, so that is the report. Now, what do you say now?
So, sir, it is a T3B N1 M0 disease, sir. So, that is a very high risk, locally advanced CA prostate, sir. So, I would like to discuss this management with this patient, sir. It would be a shared decision making and in a multimodality approach, sir. So I would like to give options as the patient is young, sir. So my first option would be radical prostatectomy with adjuvant therapy based on this report, sir. And second option would be radiotherapy in the form of external beam radiotherapy plus long-term ADT, sir.
So why do you choose the first option?
Sir, as the patient is young, having LUTS, sir. So, of course, I would like to look for this life expectancy, but by considering this age, the life expectancy would be more than 10 years. And along with this LUTS symptoms, surgical options would be better in terms of disease as compared to this radiotherapy, sir.
Okay, so when will you plan surgery?
If the patient is, sir, fit, as of now, sir, already after the 6 weeks of biopsy, sir, we can plan, sir.
Okay, so you are looking at a patient who is 4 + 5 9 with PSMA PET scan showed that there is no SUV or PSMA avidness in that right external iliac 13 by 11 millimeter node, right? So 4 + 5 9 also kind of indicates in our minds that there can be disease which is periprostatic, microscopic extraprostatic disease, which may be totally missed by the MRI. The only solace probably here is the rectal plane looks okay. That the seminal vesicles are involved, we know already. So question is, how confident are you about the PSMA PET CT scan saying yes, node is positive, or no, the node is not positive?
Is there any SUV max has been mentioned?
For the node, it has not been mentioned.
Rather they have written no significant tracer uptake.
So sir, the sensitivity and specificity for these node positivity is higher for the PSMA PET as compared to this MRI, sir. So I would rely on this PSMA PET rather than MRI, sir.
Okay, so you 100% rely on the PSMA PET.
Yes, sir.
Because so many
100%.
times they say PSMA PET has a small lymph node as an avidity, it doesn't come positive
दादा
at all.
मैं थोड़ा लेक्चर
So
में
many
हूँ, मैं
times,
उसको उसका भेज देता हूँ थोड़ा टाइम में.
so many
हाँ,
times
मैं
we
भेज
see
देता
that
हूँ.
there
ओके
is
सर.
no PSMA, but nodes do come positive.
So, Hussain, here you have to
Do
talk
you
about the
ever
positive and
use
negative
any
predictive value.
nomograms or anything?
Yes, sir. So we can look for the various normograms also, like in the form of Briganti or MSKCC, and we can calculate this percentage, sir. And based on that, we can take a decision also.
Okay. Based on that, what decision you will take?
So, means the positivity of this lymph nodes, or if this Briganti is showing that that is a more than 5%, then it would be a possibility that lymph nodal positivity would be higher, sir.
Okay, so that is one way of looking at it. Another way is considering that the lymph node by the short axis diameter is positive. Other way is PSMA avidness shows is positive. So there are these 2-3 things you keep in mind. There is no sure end to that. So this patient is 68. First option or the second option?
Yeah.
And 4 + 5 9. How will you counsel if you have to do surgery? How will you counsel a patient of 4 + 5 9?
So just only the positive point is that, sir, this life expectancy would be more than 10 years, but the drawback is also there that we may
He
require
has a life expectancy of 30 years.
Not 30 years, but sir, more than 10 years we can expect. But based on this rest of
More
this
than 10 years na bahut vague ho jata hai. So you say 10 years or you say something like that. He doesn't have comorbidities, right?
No, there are no comorbidities.
No comorbidities.
So 68 plus, you can say 15 years. What is the average life expectancy in urban India?
Not sure, sir.
Okay. I think we need to find out.
See, another way is to just ask in his family how much his
Family life expectancy.
yes family life. That is a very easy way. Okay.
That we commonly assess that way in the clinic.
And and the urban is about 80 to 82 years minimum.
So this
That's the
patient
way,
has at least 12 to 15 years of life. So you can take that.
that's
So considering 15 years, what do you think is the best decision?
so surgery would be the first choice, sir.
So you will have to say the question was
So Hussein, I want to ask you one question.
Yes, sir.
That looking at the disease, even if you do radical prostatectomy, what are the chances of recurrence at the same site?
Around, sir, 40 to 60%. If it is a locally advanced grade 5 disease, so the chances of recurrence would be around 40 to 60%.
So then why you want to do it? How it will help?
Yes, sir. So it is, of course, a shared decision making, sir. But by considering, so there are the pros and cons for the both treatments, sir. But the data is supporting for the surgery along if this life expectancy is good, sir. So
I
I
agree,
have
but what
option.
are the advantages of doing surgery? Even though you know that there are chances, as Dr. Ganesh Bakshi has said, that this is a locally advanced, there are chances that you are going to have a positive margin. There are chances that after surgery, patient will have a distant metastasis, may develop after 1 year, 6 months, 2 years. In spite of that, you are saying that I want to remove this local cost. What are the reasons?
So, sir, if we are removing the complete disease, the chances of recurrence would be lower as compared to this radiotherapy. That is one advantage.
Hussein,
Yes,
see,
sir.
with 4 plus 5, 9, I really cannot guarantee that I will remove complete disease. Very honestly. I'm sure that I will have extra prostatic microscopic extensions in this 4 plus 5, 9 left side. So this won't happen. So I was just answering that halfway through the same question. So it goes like this. Patient seems to have obstructive complaints. The prostate seems to have a median lobe. There would be possibly very good local control if we do the surgery when the patient is going to survive for the next 15 years. If we don't do surgery, this 4 plus 5, 9 is grossly going to grow locally and trouble the patient, causing a lot of BOO horribly, altering the anatomy down there and making even channel TURPs repeatedly difficult with SOS, loss of continence because of prostate growing into the sphincter, vagere, vagere. Coming back, how will you
And
counsel
causing
the
the
patient?
upper tract obstruction.
Yes, it will eventually seep below the trigone, go periuretral and cause upper tract obstruction, as sir is saying. That is also very important point. So exactly about the surgery or first option, if I say, ask, how will you counsel the patient? See, you can't end up with saying, I'll do surgery. वही तो बोलो.
So can you repeat again the question? Can you
How
repeat?
will you counsel the patient about need for
Means,
radical
or your
prostatectomy?
first option, how will you counsel me? Suppose I am a patient, so how will you patav me the first option?
So, sir, is the patient having LUTS symptoms, sir? So, if we will do this radiotherapy, the chances of this worsening of LUTS would be higher, sir. That is first thing. And if there's a patient having this large median lobe along with this large prostate, sir, and the life expectancy is around 15 years. So uh, uh, it is better to remove this whole disease gland. It would be advisable, sir. That
Is
is my
that all?
explanation.
So
When you counsel about the surgery, you will have to tell what do you remove, how do you plan to remove, what will be the effects on my body, how will be my post-op recovery, will I do well, will I die in the surgery? You will have to tell everything, man.
So it would be, sir, a radical prostatectomy. Along with that, we will remove this lymph node. So it would be a extended pelvic lymphadenectomy, sir. Means post.
So which lymph node groups, doctor, you will remove?
Sir, it would be a obturator group of lymph nodes, hypogastric, external iliac,
Hypogastric
and
means internal iliac, correct?
internal iliac, sir. Yes,
Yeah.
sir. And presacral group of lymph nodes, sir.
Okay.
External iliac and presacral.
Okay. So if you are saying extended, why not common iliac?
Sir, it would be a super extended, sir.
Okay. So very super extended. At the aortic bifurcation, at the common iliac bifurcation,
Aortic bifurcation, sir.
then why not common iliac?
I'm not sure, sir, which survival it is, but I think it is disease-specific survival or oral survival
At
is.
least many people have heard. If we are planning a lymph node dissection in prostate cancer, radical prostatectomy procedure, we do extended, correct?
Right, sir.
So there is nothing like only obturator or only two nodes from both sides or only external iliac or only something. About the presacral which you mentioned, presacral are actually most important in bladder cancer.
Right, sir.
They particularly mention presacral. So these two organs, bladder and prostate, have a very specific prostate lymphatic drainage, which is mentioned in one of the UCNAs. So even if you do robotic surgery, going to the common iliac for lymph node dissection is easy only. Only thing is, it takes time and many people don't want to give that time. So don't go on that habit ki not common iliac. Common iliac is done. So literature also says that at many times where the ureters cross the common iliac, you can at least remove the bifurcation and up to that level.
Bifurcation of aorta, sir.
Nahi re. At least the
at the crossing of
ureter
iliacs.
crossing at the on the common iliac.
So all lymph nodes beyond the crossing of iliacs.
So coming back to your counseling, what will happen now? You said prostate and lymph nodes, and
we would keep this catheter for this
in
longer
most
time.
patients, seminal vesicles are also different organs. So make it a practice to say prostate with seminal vesicles and lymph nodes.
Sir. So prostate with bilateral seminal vesicles along with this extended lymph node groups, we would like to remove during the surgery. Post surgery, we would keep this long-term catheter at least for 10 days. And post catheter removal, there is a possibility of urinary incontinence. And along with that, the patient may have a complaint of erectile dysfunction for a longer duration.
So can you save that erectile dysfunction for me?
Yes, sir. So in the posterolateral zone, sir, there is a neurovascular bundle.
With reference to this patient only.
Will you like to do it?
No, sir. In these patients, no, sir.
So you should counsel me directly that I will not do a nerve sparing surgery in you.
Agree, sir.
Okay. Here the focus is going to be going as radical as possible. Okay.
And talk about the
by 9 or
VARs
grade group 5, you will tell probably that you will have erectile dysfunction. Clearly. Okay. And what do you think about my simple question, doctor? Will you be able to remove my all disease?
No, so based on this histopathological reports, sir, if there's extracapsular extension or seminal vesicle positivity,
No, that is
or
after the surgery. You are counseling me 10 days prior to surgery. Don't go on the histopathology. There is no histopathology available right now. You counsel me. Grade group 5, you are doing radical prostatectomy. My question as a patient to you is, will you be able to remove all the disease in my body?
uh,
Your partner can also answer. Na? He's
Sachin.
looking like he wants
Sir.
to answer.
Sir, even
Yeah,
after
Sachin, you can answer.
yes, sir. Even after a complete radical dissection, there are higher chances of the post-operative positive margins. So patient may require the post-op radiation. We have to counsel the patient because group is already 5, grade 5.
Okay. So then, doctor, if you are going to give me post-op radiation, then again my simple question, why do you want to operate me? Why do you want to do radical prostatectomy?
Sachin,
There are
I mean, the
why you want
answers
to
are
do?
the ones which we discussed already, actually. Don't get psyched by me asking this again. I can ask you anytime. Answers we discussed just prior to this discussion.
You said na, that why you don't want to give radiation therapy. The answer that only.
But then
May-
coming
Right.
back to your second option, you said you will give radiation. You will give something else after radiation, before radiation?
ADT also may require it.
अरे
But
थोड़ा
all
जोर से बोलो.
patient may also require ADT, but all these options will be after histopathology reports.
So biopsy report, okay, you are saying after surgery. No, we have not done surgery yet. We finished just counseling about the first option. Now you counsel me about the second option.
So, Sachin, patient is telling you, okay, sir, someone has told me that I can take hormonal therapy before and then you do my surgery, it will be better. What is your say on that?
Sir, in literature also, neoadjuvant role is still doubtful, sir. Not justified. In any protocol, they have not mentioned that neoadjuvant should be given to all localized disease.
And if he says, okay, but no, your surgery will become easier. Sir, chances of my injury to other organ will be less.
With neoadjuvant, sir?
That is what someone has told him.
So Sachin, you just said that in literature something about neoadjuvant therapy. So neoadjuvant ADT has been studied once about 15, 16 years back, and then about in 6, 7 years back, where it was used with patients who were given ADT plus abiraterone. Okay. And then very recently, last I think 2 months or something, there is again a study with respect to ADT. I don't remember exactly, ADT plus apalutamide or only apalutamide before surgery.
I think
Okay.
apalutamide, Ganesh.
Apalutamide
Apalutamide, okay.
before surgery.
Hmm.
So what was seen in these at least 2 studies, do you know? ADT and ADT plus abiraterone?
Sir, sorry, sir.
So what was seen in these studies when neoadjuvant therapy was given? First with ADT and the other one was ADT plus abiraterone.
that is, sir, before surgery, you mean to say?
Yes, neoadjuvant is always before.
So, sir,
Sir, sorry. Surgery was more difficult, sir, due to
It's not a question of surgery is difficult, right? What I'm asking is, what difference did it make? See, all those studies, what did it was ADT and then radical prostatectomy and ADT plus abiraterone and radical prostatectomy. So I am saying, what were the kind of results seen in these studies?
no idea.
so recurrence or metastatic free survival was better, sir. I'm not sure.
So what was good or what was not good?
But that was a sir, very old study, sir. There is no
Correct.
guideline has been mentioned, sir, about this neoadjuvant ADT before the surgery. There is a proven data for this neoadjuvant ADT before the radiotherapy, sir. but not
Okay.
about the surgery has been there, sir.
So
No
what
single RCT, sir.
what it was thought it does not affect the PFS that time, the studies with ADT, but it did reduce the incidence of positive surgical margins. That was seen with ADT plus abiraterone also in a strong way, but the ADT plus abiraterone again did not probably show an improvement in overall survival. And the near trial which I am saying about neoadjuvant apalutamide and radical prostatectomy, so in that they had a endpoint of receiving PATH-CR. Okay, PATH-CR means if you give that therapy, you expect no tumor in the pathology. So that endpoint was not achieved. But it still kind of achieved some lateral endpoints like maybe reducing the size of the prostate, making the surgery slightly easier, and the old endpoint of surgical margins happening good. That is the near trial, NEAR. Okay. So, kind of, it has still not come into guidelines in any way. But there are a few series here they published about neoadjuvant hormone therapy before radical prostatectomy. So remember that. I have personally used it quite a few times when there has been too large a prostate. You know, it really reduces the size. But what I have been using is the injection Degarelix, which seemed pretty good. I have done radical prostates even after using leuprolide and pamorelin. But I always feel the field is slightly more sticky when we use LHRH agonist and much more better if we want to use neoadjuvant Degarelix. It is not very standard answer in exam and it does not come into guidelines at all. So
Sir, no
coming
role
back,
of chemotherapy, no, sir? Some
role of
neoadjuvant chemotherapy, so some studies were done, but there's no
neoadjuvant
role.
chemotherapy has failed completely. There is no role of neoadjuvant docetaxel. All the studies have not shown any benefit. Okay. So how will you counsel for the second option?
Sir, in examination regarding neoadjuvant hormonal therapy, sir, what should we answer, sir, then?
So generally don't answer as Pankaj sir said. It is not a
Okay.
very standard thing. Or if you answer about neoadjuvant therapy, you will need to know these points. Reduction in size, getting pathological clear margins. These are the probably two objectives which can be used.
Okay, sir.
In selected patients, that would be a better answer.
So I have put
that too
one
if the
recent,
examiner presses you. Otherwise, say not a standard practice. That is better.
I have put one recent article in the group, in the chat.
Yes, sir.
So you can go through it and it will give you some idea. ठीक है जी. So
Will you counsel for the second option?
for the radiation, how do you counsel for the radiation?
So, sir, for the radiation, sir, we can counsel regarding like we can avoid the morbid surgery. Apart from that, the incontinence and the ED results are still better as compared to the surgery. So, by comparing the pros over this surgery, sir, we can explain about this radiation, sir. But along with that, we may require this neoadjuvant or concurrent hormonal ADT for a longer time, sir. Audible, sir?
Yeah, but I kind of didn't understand much of your answer. Sorry.
Should I repeat again, sir?
Yes, if you don't mind. Sorry.
So we can explain regarding, sir, the avoidance of this morbid surgery. That is the first added advantage. Apart from that, the chances of incontinence and erectile dysfunction result were better as compared to this surgery, sir. We can expect. So these are the pros over the surgery we can expect, and we can explain to the
Okay.
patient, sir.
So do you think all these things are correct then? Because first thing is, as you said in surgical option, here also the therapy is multimodality. Okay. You will need to use neoadjuvant hormone therapy at least for 2 to 3 months or sometimes 4 5 months and then proceed to radiation. This is an obstructed prostate. So I think you may require a
Channel TRP
channel
prior to this.
QRP prior to radiation.
Agree, sir.
There is a reason for that, why you do prior to radiation. Then in the end, you said something about erectile dysfunction. So when we give strong dose of neoadjuvant hormone therapy before radiation, in high risk prostate cancers, we give ADT plus abiraterone. Okay.
Right, sir.
The data,
Stampede.
stampede data is with ADT plus abiraterone with prednisolone in high risk prostate cancers before radiation. So the drug itself is going to cause ED. Forget about the radiation. And when you add radiation, it is going to probably burn off the nerves. And the last thing you said was continence, right? Continence.
Yes, sir.
So with continence may not get affected. Let me not debate about it, but there is a small chance of that also. So that is how I decipher that. So अभी क्या? What can you improve the whole counseling radiation wise? I think these are all the points which I said you can add when you are counseling. So one important thing is you avoid the surgery, you get all these things. You have not mentioned to me anything like acute and chronic side effects of radiation. Do you by chance know any one of them?
GU and GI side effects, sir.
Thoda loudly, please.
GU and GI side effect is more common, sir. The
Okay.
cystitis is more common than proctitis is there, sir.
So why do they occur?
So this, or generally we are giving this radiation to this local area, but this cells is also affected. Surrounding cells are also affected, sir. So if we are giving the prostate, the nearness of this bladder, which would be affected, sir, which leads to the cystitis.
Why it
If
gets
we are
affected? They give conformal 3D CRT, conformal radiation therapy, 3-dimensional, which is in other words called as IGRT, image guided
yes, sir.
radiation therapy. And what is basic IMRT?
Intensified modulated radiotherapy, sir.
What happens in that?
So
The peak
we are
of the
giving this.
So there is something called as a planning which is done, and the machine has a collimator where the whole beam is adjusted into the size where you want to give only that radiation, correct?
Right, sir.
Then if you are using all these things, then why does the radiation reach the bladder or the rectum?
So the chances of that GU and GI toxicity is less, sir.
Basically, it is called scatter radiation. There is some scatter radiation, okay, which affects the small part of the bladder and a part of the rectum. But then if you are going to talk about toxicities, then you should know what are the above grade 3 toxicities, GU and GI. When you said these words first, GU and GI, I thought then you will mention graded answer. Grade 3 toxicities, grade 3 plus toxicities are this much percent, and grade 3 GI toxicities are this much percent. Anyways, grossly, this all constitutes the counseling for radiation therapy. Coming back, out of these two, if the, yeah, I think then we should proceed now.
Okay, Bridges. Now, what was done and what was the result?
Plan of management, we had two plans. One was 68 no comorbidity surgery based treatment, where we would use surgery after 6 weeks and see the histopathology. And the other plan was to offer neoadjuvant hormone therapy and radiation. So radical prostatectomy was done.
Yes.
Sir, how to tell about this
Report padho.
brachy booster, sir?
So histological type was acinar adenocarcinoma, grade 5, lesion 4+5. Intraductal carcinoma not identified. Estimated percentage 25%. Extra prostatic extension present, non-focal. Left location of extension was left posterolateral and left posterior. Bladder neck invasion not identified. SV invasion was present. Perineural invasion was present. Number of location of positive margins was right posterior, left apical, left posterior. 11 lymph nodes were sent. Number of lymph nodes involved 0. So P3B N0 MX.
Okay. So what is missing in this report?
Sachin, Hussein.
The margin has not been mentioned, sir.
Margin mentioned, sir.
So generally, when they say margin positive,
Size of the margin.
ideal
Positive.
pathologist will tell you what is the lesion primary pattern at the margin.
And size of the margins.
Size of the margin is mentioned here, non-focal or multifocal. It's already mentioned
Okay.
there. Come to the next page, please.
Next slide, please.
It's mentioned here. Extra prostatic extension present non-focal and margins in the last involved by invasive carcinoma non-limited, greater than or equal to 3 millimeters. So that is technically above 1 millimeter is called non-focal. Variant histology ऐसे कोई बताता नहीं है तो बताता है. 4+5 9 में if they see more than 10% of neuroendocrine, then only they will report that. If they see less than 10% neuroendocrine, they'll not report. Going with these things, margin positive में कौन सा gleason pattern है वो लिखा नहीं है.
But they have written invasive carcinoma, so probably higher grade.
हाँ सर वो उसका मतलब नहीं है मतलब actually invasive word has no meaning there.
No meaning there. Yes.
So actually no meaning मतलब in prostate तो it is never used.
Absolutely.
Meaning is actually this final diagnosis shows YPT3B. So this patient has been given hormone therapy.
Yes.
तो इसको कितना महीना हार्मोन थेरेपी मिला और क्या मिला है?
Brijesh, I think he was diagnosed 2 years back, and earlier only we had given him. He took it for, I think, 1 or 2 injections he had taken.
Okay.
Of
LHR is
palmorelin.
agonist.
Agonist.
Okay.
And then in between he had stopped everything, and then he decided that he wants
Surgery.
surgery. So when he came, we investigated him again, and that this was the
ठीक है
result.
सर. So Hussein, what will we do now?
So, sir,
So I think ये slide show बंद करते ना अभी.
There is one more case, short case,
Okay.
if you want just
Currently ये discussion होने तक बंद कर दो ना slide show.
Okay, fine.
so,
Brijesh,
sir, Is the patient having this margin positivity apart from the seminal vesicle and this extracapsular extension is there? Sir, I would like to plan for this adjuvant radiotherapy. Before that, I would like to start neoadjuvant ADT at least for 2 months prior to radiotherapy, and followed by I will give external beam radiotherapy, sir.
Okay. So, Hussein,
Yes, sir.
one thing is that we have already done the surgery. Now, anything hormone therapy given is adjuvant only. Okay. So, if you want to give hormone therapy, it is adjuvant. It is, if you want to give radiation therapy, that is also adjuvant. Secondly, one question to you, would you like to see any PSA level or just go ahead with your adjuvant radiation?
So if we are saying, sir, adjuvant, sir, so
Pardon?
that
If you are?
if we are using a word adjuvant radiotherapy, sir, based on this histopath report, sir. So
That's what I'm asking. Do you want to wait till you see a PSA level, or you want to just proceed with adjuvant radiation or adjuvant hormone or both?
yes, sir. So now the concept of this salvage or early salvage radiotherapy is there, sir, based on this radicals, raves, and this get up trials, sir. Yes, sir. So we can choose over this salvage radiotherapy over this adjuvant therapy. So we can look for this PSA after this 3 to 6 months, and if it is going above this 0.2, then we can start the salvage.
It's not radicals and Jetak. It is raves and radicals right now. These were the last 2 trials. Okay. Secondly, it's not random. PSA at 3 to 6 months means the student doesn't know 3 months or 6 months. That is another problem in your exam.
After radical prostatectomy, sir, usually
I will ask you again. Right now, let Hussein answer. Don't talk. Okay. Secondly, you need some concrete plan to tell to the patient. Examiner will see your confidence in managing the patient. Okay. So if I ask you this question, will you wait? You need to say, okay, I'll wait and justify that, or you need to say, I'll not wait. And there are some reasons. So let Sachin answer now. The same thing.
Sir, first I would like to repeat the serum PSA after 2 months of surgery.
Why 2 months? ऐसा standard time है क्या? उसने 3 to 6 बोला, तुम 2 months बोल रहे हो?
Radical prostatectomy, sir, in books they mention 2 months.
Okay. Books have mentioned. Which book has mentioned 2 months? I don't remember the European guideline or anybody saying 2 months.
They mentioned like, sir, within
some of these BCR trials, biochemical recurrence, they have mentioned some time, but that is 6 weeks. And urology may inadvertently, whether you say cancer or no cancer, 6 weeks is a very good limit in many things. I remember.
Yes.
So if first of all you say your answer, but if you're going to see a PSA, it is at 6 weeks. Bolo tumhara answer.
Sir, I'll repeat the serum PSA and we'll give the adjuvant RT, sir.
No problem. You will do the serum PSA. Okay, at 6 weeks you do the serum PSA of this patient. I get a value of 0.08. Now what will you do? ऐसा random answer मत देना. There should be some thought behind the answer. Or you explain, matlab, I already told Hussein that you justify for either ways. We won't mind, but you justify.
0.8 is after radical prostatectomy.
0.08.
0.08.
I know you are smiling, but these reports can come as a fact. Factual hai.
Yes.
So that's what I'm asking. There should be some concept. Nahin?
Yes, sir.
Okay. So in this patient, what we saw was seminal vesicles were positive, lymph nodes were negative, non-focal margin, left posterior, left posterolateral, approximately 3 millimeters. That is what they have given. Immediately after the surgery, patient is deemed incontinent. Somebody is talking. So what happens is usually, even if I plan, say, if I plan adjuvant RT, I am not going to give RT at 4 weeks or 6 weeks. I am going to do a 6 weeks PSA. I will see the patient PSA, and then if I want to give RT adjuvant, I might give a dose of 6 months of hormone therapy and give RT when the patient gets back his continence. Okay. I will not give the RT at 6 weeks. I might wait 2.5, 3 months, let the continence come in a great way, and then I'll give radiation therapy. Okay, it is affected. Why? Because where are you giving the radiation? You are giving it to the prostate bed. If there is no continence, the bladder remains empty. You cannot plan a good radiation with the bladder remaining empty. So for planning, for getting the surface marking proper, using the soft tissues and the bony landmarks in radiation therapy, you will need to achieve some continence. So if I have to go for adjuvant, looking after my PSA value, I will give a shot of hormone for 6 months, and then at 3 months or 2.5 months, whenever I'm happy with the continence, or 2 months, I'm happy with the continence, I can go with radiation. Other way around, I will say that, okay, I've got seminal vesicle positive, I've got a 3 millimeter margin positive. I will use early salvage therapy. I'll do a PSA at 6 weeks. If it is below 0.1 or 0.15, I'll wait. I'll not do anything. I'll let my patient achieve continence. I'll keep a close watch. I'll repeat the PSA at 12 weeks from the surgery. If that is also 0.09, I'll wait. And then I'll go by the RAVE study. Okay, that is early salvage. So examiner will probably see what is your knowledge and how do you plan, where the patient's life is not affected. Only thing is, if you go from adjuvant to early salvage, the studies have shown that it is okay. But if you go to salvage, then it seems we are not so good at the battle. Salvage means things have gone ahead.
So salvage, we will use the term when the biochemical recurrence is there.
What is the definition of biochemical reference after RP?
So once achieved the nadir, there is a persistent 2 PSA, which is raising above the nadir. Then
After RP, not after RT. After RP.
so it is more than 0.2, sir.
So it is not, it is 0.2. The European ESMO guidelines say EAU all say 0.2. The American AUA guidelines say 0.4. So AUA has made, their association has taken that as 0.4 because that is a very convenient value. Many people, even I use the European value 0.2 because it is more stricter. So 0.2 is technically the BCR after RP. But when we are at 0.15 or something, it is quite certain. What you can also do is, in practice, you can see a PSA doubling time. If the PSA doubling time is not good, then I don't wait beyond 0.15 or sometimes 0.12 again, because the doubling time is important. If doubling time is lesser, I know that it is going to increase.
And
Okay.
especially in this patient with a grade group 5 disease, your threshold for salvage will be lower.
It can be lower, sir. Matlab 0.11, 0.15 may you should think that this is increasing if we are going to use early salvage.
And sir, one more
तो
doubt,
इसमें
sir.
क्या सवाल पूछा था? 0.2. हाँ, तू जो बोल रहा था definition, that is astrophenix definition
sir.
for, as sir said, for post RT BCR.
That is Phoenix criteria, sir. That is for post RT nadir plus 2, sir. So that is about the 2. And sir, one more doubt, sir. If we are saying the adjuvant radiotherapy, sir, should we means whatever the PSA value post-op, sir, is it impact on our management of adjuvant radiotherapy, sir?
Technically, the decision of adjuvant therapy, adding adjuvant therapy is going to go on your histopathology report. If my histopathology report is gross, multifocal margins positive, with seminal vesicles positive, with nodes positive or something, I might consider all adjuvant therapy. It also depends. But again, that is after nearing the continence. So when I'm going to add adjuvant therapy, I would add a hormone therapy if at all, if I think that is safer for the patient, and give radiation at a little later time. So I think, kya kare? Go to the next case.
I will, Ganesh, I'll just explain this aspect once again.
Yes,
You
sir.
can correct me if I have made any. So, if you have decided adjuvant, then your decision is not based on PSA. You have already decided to give this,
Yes.
but the decision will be give radiation after you have achieved continence.
As we are nearing the continence.
Yes.
That's a good
And
one.
if you decide for early salvage, then you wait for the PSA to rise.
Then we monitor the PSA levels 6 weeks, 12 weeks, and then 3 monthly. And as we are rising, then that is an indication. Now, I think in radicals, 0.1 was used. In raves, 0.2 was used. So personally, I mentioned what I would do in practice. I would use 0.15. But in certain patients, I would check, depending on the report, where I'm little bit scared for the patient, use a doubling time, which is not mentioned in theory, but it is a very useful thing.
And Sachin, the reason, as Dr. Ganesh had asked you about why 6 weeks or 2 months, that is based on the half-life of the PSA. With the half-life of around 2 to 3 days, 6 weeks is more than enough for the PSA to come to absolutely nadir value.
Okay, sir.
So you do not need to wait longer than that.
So Sachin, what is PSA persistence?
Even after surgery, sir, PSA is not coming down to.
So is it the same as BCR?
No, sir. BCR, first PSA will come down and then it will start rising, sir.
Okay.
In persistent, it will be persistently rising even after the definitive treatment.
So are the reasons for both the same?
No, sir. In persistent, there is some malignant diseases there left behind at the residual site. While in BCR, it may be some benign cause also may be there, or malignant, or the extra prostatic PSA secretion.
No, but if BCR is there, you are crossing the BCR level, then we are not thinking benign. If there is some benign glands left, the PSA might rise, but it doesn't come to 0.2. So BCR.
BCR is due to the recurrence of the local disease, and
recurrence is due to left behind microscopic disease only. That is what I'm asking you. You said in persistence the disease is left behind.
Yes, sir.
Now in BCR you are saying नया disease पैदा होता है, de novo तो पैदा नहीं होता है. It is because of microscopic disease where the margins are positive left behind, right?
Yes, sir.
So there is one small thing in that. BCR is usually due to local recurrence subject to microscopic disease which is left behind. PSA persistence can be due to gross disease which is left behind locally, or there are occult metastatic disease systemically. Remember that.
Yes, sir. Okay.
So दूसरा केस करें. So raves and radicals you need to study properly. Yeah? Here the discussion comes to raves and radicals. So there is one question in the guidelines which can be asked to you. As an adjuvant therapy, when will you use only ADT, when will you use only RT, and when will you use the combination of ADT plus RT?
In high risk disease, sir, we should give ADT with RT with ADT, sir, at least for 2 to 3 years.
What is your definition of high risk disease? ऐसा एकदम gross answer दोगे तो you go back again to ABC level. What is the definition of high risk disease? Broad statement you made. बोलिए sir.
T3 or more, T3 or higher disease or any node positive or extra prostatic extension is there.
तो वो तो बहुत बड़ा फेज हो गया ना. So कुछ स्पेसिफिक बात करो. So guidelines actually give you a choice of using these three. So it is about when I will use these three. So if it is just local bed recurrence as a BCR, Many radiation oncologists or oncologists will plan only for a radiation therapy. If it is going to be a, say, some gross disease seen, matlab the BCR comes where there is also a sizable disease in the prostatic bed, then we would use hormone therapy to downsize it and then give radiation. If the disease has gone such that there are many, with the BCR, there are many nodes positive in the RP as well as during the BCR, grossly nodes positive, very elderly patient, then sometimes you can give only ADT. There is no specific thing to choose that, but according to the gravity of the situation. But all these three options are given to you.
So just to explain this again, if your BCR is there and your PSMA PET is negative, that means you are
Maybe we can use
suspecting,
only radiation.
then you can give only radiation. But if PSMA PET shows disease in the field, then you give a combination. If it is purely metastatic, then you can give only hormone.
ADT.
So your decision will be based on the PSMA PET at this time.
Any one of you two can tell me something about the EMBARK study?
It is enzalutamide based study, sir.
Yes, you can Google and tell me, but tell me. No problem. आवाज नहीं आ रहा है बराबर.
It is the enzalutamide which is given, and when PSA comes normal, yes sir.
Yeah, correct. Go on.
They give the enzalutamide as a adjuvant. After certain weeks, when PSA comes below the RD level, they stop the enzalutamide. Again, when PSA starts rising, again they have given the enzalutamide, sir.
Intermittent.
So there are improved. EMBARK study says that when you give, usually what we give is we give leuprolide. I mean, we give hormone therapy. EMBARK study says that you give enzalutamide plus hormone therapy, which does quite a bit of improvement in metastasis-free survival. So this is in the case of high-risk biochemical recurrent patients. So remember that. This is a new study, I think published in 23 late or something. So it will be important to you. EMBARK. Okay.
But
So we go for the next.
does it talk about intermittent enzalutamide? I don't think.
No. It talks about continuous ADT plus enzalutamide versus only ADT. Matlab, leuprolide plus enzalutamide versus leuprolide. And the comparative thing is for metastasis-free survival. Ekdam details I can't tell you, but I can post it in the group.
I think, sir, we had a good discussion. It's already 11.
Yeah, we can stop also. It's 11 ho gaya actually. Maybe if things are there, we can continue next time and then start with the next time ka topic.
Next time we can have one more case and then continue discussing. That would be a good idea.
बचा हुआ case भी ले सकते हैं.
Okay.
Sir,
Better, na?
in what situation we will advise intermittent ADT, sir? In which cases? Intermittent ADT.
So in these situations which we discussed today, I don't think there was any role of intermittent radiation. Radiation नहीं, hormone therapy.
ADT, yes, ADT.
ADT. इसमें कोई खास रोल नहीं है. So only one thing was, if you are using radiation therapy option for high risk prostate cancers, I said in that Stampede data says use ADT plus abiraterone. So technically, abiraterone is used for 2 years. The
Yes, sir.
ADT was earlier used for 3 years. Then the data has come to 24 months. Then the data has come to 18 months, which is comparable. Something like that. So it is left to the clinician whether to use both for 2 years, ADT plus abiraterone prednisolone, or use ADT for 18 months and abiraterone for 24 months. That is one thing I would say. Easy to say in exam is use ADT plus abiraterone for 2 years. Means
Is
you
there
can
any
start ADT plus abiraterone, have a good reassessment at 2.5, 3 months, add radiation to the patient. That is one thing. Only one point which was missed in this whole discussion was if you are going to do a channel TURP for a patient who is going for radiation, it is better that you start the patient on ADT plus abiraterone, do a channel TURP, let the wounds heal for the next 2.5 months, and then consider radiation on a completely healed prostate. Post-radiation TURPs often lead to incontinence. If you give radiation when the TUR wounds are raw before around 2 months, then there is a chance of having complications such as stricture, cicatrization, vagere.
Very high chance of dystrophic calcifications.
Yeah. So remember that. That was the only thing left.
So any patient who needs deobstruction, it is better to do deobstruction first and then go for radiation. And as sir said, hormones, deobstruction, wait for 2 to 3 months and then start radiation.
So I think we have covered locally advanced prostate cancer with this case in actually a very good way. Most of the points we have touched. As you really said, younger patients, we choose surgery. Selected patients, we choose surgery. Selected node positive patients, we would choose surgery. So surgical options, there cannot be head-to-head trials of surgery versus radiation in this particular group. There is one trial, SPCG15. If anybody has read what is the trial about, it is still accruing.
Yes, 2025 the data will be published. Yes.
SPCG15.
Yes, sir.
It is about
Data collection is
agreed, but it is about what?
So surgery versus radiotherapy, RP versus RT.
In locally advanced prostate cancer. So that was my last question actually. So we don't have a upfront data. That's what I was coming to. Ki kisko surgery or kisko radiation. Conventionally, we have been giving neoadjuvant hormone, radiation therapy, and adjuvant hormone therapy to all these patients. Since the advent of robots and a lot of people started doing robotic surgery, we have been using surgery as also a prominent mode of giving treatment to these patients, and especially younger, fitter patients. So SPCG15 is a randomized trial, surgery versus radiation, and that would probably put more insight into how we do it. Okay, so you should remember that SPCG15 when locally advanced prostate cancer comes in the discussion for you all. So couple of trials we did speak, SPCG15, Embark, Near, then the prostate MRI ke bare mein there are few trials, Promise, Precision. Okay, so these 2-3 things you remember. There is a study about transperineal versus transrectal biopsy. Uska meta-analysis ka report hai. I mean published hai. So these are the few things in today's discussion where there are proper published studies. Just tomorrow evening, just go back and read fast through these 6-7 studies. It will be helpful.
Sir, any role of novel markers in deciding sensitivity to radiation or hormonal therapy, sir?
So, अभी तक established nahi hai. There are evolutionary roles. About ADT, I know there is a SPOP mutation which is there, but that too, when you do NGS, your writing it is okay. Don't quote to your examiner, but because they will not know. So SPOP mutation, whenever it is present, it is a very good candidate for a hormone therapy. But then this also comes, all this comes in advanced prostate cancer. It has still not dropped down to the below that. So likewise, AR7 splice variant present,
ARV7.
abiraterone and enzalutamide doesn't work well, So there is role which is all getting, the evolution is coming up. And in prostate cancer, which is one of the prominent cancers above the age of 60. In India also, it has come almost number 1 or number 2 right now. Number 1 at most places above 60 in men. So these markers are going to get a good role in the successive years to come. Like we may be able to choose some therapy here there because of these markers.
And sir, in cases of local margins positive only and no lymph nodes on the specimen, sir, do we go for a whole pelvis radiation or radiation to the bed, sir?
So if it is a focal, unifocal margin positive, I might not do anything. If it is a multifocal margin positive at various multiple sites, I might go for adjuvant radiation. Now I told you already how I will think of giving ADT. I'll wait for my continence. So if it is a multifocal, multi-site margin positive, I will give 1 dose and wait for my continence. तुम्हारा question क्या था?
The whole pelvic radiation or radiation to the bed only, sir?
Prostate bed only usually. So it depends now. Matlab in oncology, what happens is there should be usually a tumor board or a discussion. So we'll have to see how many lymph nodes have been dissected, what areas have been covered. All these things remain important. At 3 months' time, when I'm going to give radiation, I might as well do one MRI or something to plan my radiation therapy if I'm a radiation oncologist. In that, I will definitely see for lymph nodes. Say if you are doing the surgery, you have not done, you have just removed 8, 9, 10 lymph nodes. I mean, that is not so good.
Sir, here 11 lymph node has been dissected, sir.
I
Camber
know,
is
you
saying
find out
around.
the level of lymph node. There is a lymph node number here also.
Yes,
13, sir.
13 or 14. So ideally, that is a good
13.
number.
USI में sir 13 mention किया.
Correct. Okay. Gaurang Shah sir, so we carry on for next time. I think Pankaj sir, आप ही है senior, तो आपका decision taken already. So we stop the meeting on behalf of Pankaj sir.
No. Ganesh, in your presence, it has been a wonderful discussion.
Thank you, sir.
Really learned a
Superb
lot.
discussion.
We'll
Thank you,
join
man.
next time. Yeah.
Yeah.
Bye.
Thank you,
Good
sir.
night.
Thank you, sir. Thank you, sir.
Good
Good
night, everyone.
Okay,
And
sir.
both of you have done very well, Sachin, Hussain.
Yeah, truly, very well. Answered very well.
Yeah,
Thank
keep on doing same way and make your teachers proud.
Bye.
Thank
Good night, everybody.
Good night.
Okay.
Good night, sir. Good night.
Good night.
Good
Good night.
night.
Hitesh
Good
sir,
night.
Pankaj sir, Ganesh sir.
Good night, sir. Yes.
Good night,
And yes,
students.
and we will discuss in our group. Okay?
Yeah.
Okay, good night.
Good night, sir.
Good night. Brijesh, you have to end the meeting, huh?
Brijesh.
You are the host. Otherwise, it
Brijesh.
will not be recorded.
Brijesh.
ब्रिजेश सुनाई देता है?
Sir, I will call him. Sir, I will call him.
हाँ, okay.